Welcome back to Corium. I'm Brian Gilberti, and joining me today is Dr. Jonathan Kobles, Assistant Professor and Co-Editor-in-Chief at Corium. Welcome back to the show, Jonathan.
Always a pleasure.
Together, we're going to be talking about a common scenario we encounter in the emergency department, acute agitation, and one that deserves some discussion because of the impact it can have on patient and staff, and that it can be so heterogeneous in its form. So, Jonathan, can you start us off with a broad definition of acute agitation?
Absolutely. Agitation encompasses a spectrum of behavioral patterns, ranging from restlessness and hyperarousal to severe states of altered mental status and increased psychomotor activity. It is a frequent presentation in the emergency department and one that is often associated with a high risk of morbidity and mortality for patients. Most often, patients presenting with agitation are typically experiencing some form of acute medical emergency, an acute intoxication, often with sympathomimetics or alcohol, or a behavioral or psychiatric emergency. Managing agitation can be challenging due to various factors, including the possibility of a critical or life-threatening medical condition that these patients may be experiencing, and barriers and delays that the agitation itself may cause in the rapid recognition and treatment of an underlying condition. This is further complicated by being in a state that increases the risk of harm to both patients themselves and the treating healthcare teams. As with many conditions that present with varying etiologies and severities, it is crucial that emergency providers adopt a unified approach in recognizing and treating agitation while appreciating its many complexities and nuances. And before we dive in, I'd like to also bring up the point that historically, the medical community and general society, including news entities, have used terms like excited delirium or agitated delirium to describe severe states of agitation. These terms have been associated with high-profile cases that have become politicized in recent years. In alignment with the American Medical Association's guidelines, my goal in this episode is to avoid using such terms and instead describe agitation in terms of increasing severity, emphasizing that ultimately, agitation is a presenting symptom that can have multiple underlying causes.
Okay, Jonathan, so we've set the stage by highlighting the importance of understanding agitation beyond these stigmatized terms, another common example being EDP or emotionally disturbed person, while focusing on its severity and underlying causes. Now, describe your general approach when faced with a patient presenting with agitation. What are you emphasizing in the initial assessment, and what are some intervention strategies that you employ?
When a patient first presents with an agitated state, my priorities involve assessing the severity of agitation, considering reversible causes and time-sensitive life threats, and, like any other disease entity, forming a differential diagnosis. For patients who present in severe states of agitation, including those with significant changes in mental status or showing signs of decompensated psychosis, or signs of sympathomimetic drive, such as increased pain tolerance, diaphoresis, unusual state and abnormal vital signs including tachycardia, hyperthermia, or aberrant blood pressure, it is crucial to recognize that these patients require rapid treatment before you're able to facilitate further workup. The longer that these patients remain in an agitated state, the higher the risk of self-injury or harm to the staff. These patients often have the highest mortality rates related to their agitation, and this could be related to a trauma or an evolving medical condition. Further, agitation in this severity can lead to secondary emergent medical conditions, such as rhabdomyolysis. For these patients, once I have gained sufficient control of the initial situation, my next steps involve evaluating for reversible causes of altered mental status, including hypoxia, hypoglycemia, pain, trauma, head injury, and acute neurologic emergencies. Paramount to this evaluation includes obtaining a full set of vital signs, checking blood glucose levels, performing an EKG, and conducting a targeted medical screening exam where I evaluate for trauma, neurologic deficits, or signs of an underlying toxidrome. During this process, I'm also trying to gather more information from the patient, from EMS, and from chart review to try to develop a differential diagnosis for the patient's underlying agitation. I find it helpful to consider both underlying conditions that can lead to agitation as well as acute exacerbating factors. Examples of underlying conditions may include dementia and neurocognitive disorders, primary psychotic disorders, communication difficulties, poorly treated or decompensated medical comorbidities, unmet social needs, autism, or behavioral disorders. Secondary exacerbating factors to consider may include recent substance use or withdrawal, conflicts with authority figures prior to arrival, sleep deprivation, medication non-adherence, just to name a few. Once I've evaluated the patient, gained a better understanding of their agitation severity and clinical stability, and developed a prioritized differential diagnosis, I can then devise the best therapeutic plan for the patient based on the urgency of the situation and the suspected underlying cause.
Great. So we've outlined our approach, and the most common situation in which we encounter acute agitation is a patient brought in that way by EMS, and sometimes with NYPD assistance. But this isn't the only presentation, as we all know. Agitation can rear its head in patients who are already waiting in the emergency department. So tell us about how you approach these situations and gauge when irritation might turn into agitation.
For sure. We have to acknowledge that for the majority of patients who experience agitation in the ED, their symptoms develop following initial evaluation or during their stay. Recognizing signs of escalation and agitation is crucial, as the earlier we intervene in these cases, the more successful we can be with less painful and aggressive therapeutics, and we can also prevent potentially harmful situations for both patients and staff. Signs of escalating agitation may include initial passive aggression or hostility towards staff, patients who are pacing in the room, refusal to comply with nursing direction or follow simple commands such as staying on a gurney, loud and pressured speech, as well as signs of self-escalation when a patient is verbalizing intrusive or internal thoughts, are also worth noting. Patients with a history of previous ED visits involving violence or agitation and patients arriving already restrained by EMS are also likely at higher states of developing or presenting in agitated states. Unfortunately, there are times when there is no warning, and violence and agitation can occur rapidly and unexpectedly. I think we all have experienced a situation in which a patient has struck ourselves or a coworker without any warning, acting either volitionally or not. And situations like this are really difficult not to take personally, and often we persevere on them for the rest of the shift or even days after.
Yes, and that's one of the hardest parts of this job, right? Workplace violence is a plague that tragically affects all departments. And this is an important point, that the way we navigate these situations may help prophylax against these egregious, disheartening moments. And perhaps one of the most important components of this episode is going to be this. Now, talk to us more about your approach to maintaining safety and delivering care in these tense scenarios.
The first step I recommend when dealing with a violent or agitated patient is to start by performing a self-check-in. These patients can be among the most challenging to treat and cause anxiety that hinders rational thinking and actions. By taking a moment to calm yourself and mentally prepare for the situation, we can recognize that ultimately, agitation is a form of human suffering, and we have various tools to relieve it. This allows us to approach these situations professionally and prevent lapses that can lead to further escalation in patient behavior. Also, acknowledge that your team, including nursing staff, technicians, and security, are likely experiencing similar anxieties as yourself. It is our responsibility as providers to act as leaders to the team. This involves being clear about your goals and thinking toward the situation while verbalizing your thought process to the team. Try to develop a concrete plan before approaching the patient and support the specific needs of your team, especially when others are showing signs of discomfort or uncertainty with the situation. Instilling confidence and clarity will help these situations go smoother with less unanticipated events. After each encounter, try to have a clinical debriefing where you can recognize what went well, what didn't, and identify those team members who may need further emotional assistance after the event.
Jonathan, it's a critical balance when addressing acute agitation, wherein we have dual priorities of ensuring safety, both physical and psychological, for staff and for patients. Leadership is key in these situations, and I know that these exchanges can take a lot of different forms, a lot of different shapes, and it's impossible to give blanket recommendations, but what is the general approach you suggest?
My first intervention is always verbal de-escalation. And I break this down into 3 main domains: safety, therapeutic alliance, and establishing a sense of choice. First is always going to be safety. We should provide these patients with personal space whenever possible to reduce any unexpected physical assaults towards staff and demonstrate respect toward the patient. When entering a room with an agitated patient, we should ensure that there is always an escape route between the patient and the door, and plan the physical approach with other involved team members before you enter the room so everybody knows their place. When attempting to establish a therapeutic relationship with a patient, try to provide emotional space and allow the patient to communicate their needs. Maintain honesty, as a therapeutic relationship can be destroyed instantly by a patient who thinks you're attempting to manipulate them through lack of truthfulness. As you are able to engage with the patient, attempt to identify specific values and offer optimism. Telling someone that you recognize their suffering and that you think together you can find a solution can sometimes go a really long way. And when patients ultimately disagree with what you think is best for them, continue to provide support and verbalize that your ultimate goal is to help them. This may include simple things such as offering food and beverages when appropriate, or providing patients time to gain control of their emotions. Lastly, is provide opportunities for choice to maintain a patient's sense of autonomy. Whenever possible, try to offer reasonable choices, but always establish clear limitations and be honest when a patient's expectations are not possible to be met. Try to offer alternative options when you and a patient disagree.
Very good points, and a good starting point for a lot of these scenarios. Now, let's say that these measures prove ineffective and our hand is forced to medicate for the patient's safety and for the safety of staff, and at times to allow for the completion of a medical evaluation. Talk to us about what is in your toolbox, starting off with determining the best route of administration.
Yeah. When verbal de-escalation is futile, the next step is definitely to consider pharmacologic options. I do try to think about whether a situation may be managed with oral medications or if I have to jump to intramuscular or intravenous medications. In my practice, I've been surprised by the amount of patients, even those in pretty moderate to severe states of agitation, who can be managed effectively with oral medications if administered at the right time with the right approach. Oral medications can be as effective and offer additional benefits such as empowering patients with a sense of autonomy and avoiding potentially harmful situations. The most effective medications in these situations are antipsychotics and benzodiazepines. Initially, I try to assess if a patient, particularly those with underlying psychiatric diagnoses or prior ED evaluations for similar situations, are familiar with suitable medication options. In these cases, I like to offer patients their home medications, as they're much more likely to be receptive to taking a medication that they are already familiar with. For patients not on established medications, I typically start with 5 to 10 milligrams of rapidly dissolvable Zyprexa or 1 to 2 milligrams of Ativan, depending on what I suspect is the cause of the agitation. In cases of more moderate agitation or patients who are showing signs of an acute substance use, such as obvious sympathomimetic toxicity, I may even offer both an oral antipsychotic and benzodiazepine at the same time. For those who are in a less agitated state, or those who are demonstrating signs of anxiety or frustration, I may start by offering a mild anxiolytic, such as hydroxyzine, also known as Atarax.
And you raise a good point that we should be tuning into the impact that we are going to be having on the patient long term if we choose an IM or IV route instead of choosing a PO route, and giving them agency in their care when possible. Now, moving on beyond verbal de-escalation and PO medications, and we know that we are going to be giving a medication either IM or IV, can you give us an overview of which medications are available and which are recommended?
I think this is a great time to jump right into the recent 2023 ACEP guidelines that specifically address critical issues in the evaluation and management of patients presenting with severe agitation. The committee made 2 recommendations. The first, a level B recommendation, suggested that the combination of droperidol and midazolam, or an atypical antipsychotic with midazolam, had the most rapid and efficacious treatment of severe agitation. If only a single agent can be administered, the use of droperidol or an atypical antipsychotic alone was recommended over midazolam due to adverse effect profile of midazolam. For emergency departments without access to droperidol or alternative atypical antipsychotics, the committee recommends using haloperidol alone or in combination with lorazepam. Interestingly, this article did not address the combination of haloperidol and midazolam specifically, although I find in my own practice at a shop that does not have droperidol, I am typically reaching for a combination of haloperidol and midazolam. Typical starting doses of haloperidol include 5 milligrams, or in patients who you suspect are going to require higher dosing, 10 milligrams. This is often paired with 5 milligrams of midazolam or 2 milligrams of lorazepam. Droperidol can be given initially at 2.5 to 5 milligram dosing or at 10 milligrams for patients who you suspect are going to require a larger dose. In addition to these medications, the ACEP policy also recommends the use of atypical antipsychotics, the 2 most common of which are going to be ziprasidone, also known as Geodon, and olanzapine, also known as Zyprexa. Just be prepared that your formulary may not have these on standby, and it may take longer to come from the pharmacy. Also be aware that ziprasidone, or Geodon, takes time to prepare as it comes in a powder form, and this may be disadvantageous in acute situations.
Yes, and it's going to be impossible to predict who's going to require higher doses. You can always give more medication, but you can't take it away. But maybe you can reverse it. And this mirrors our practice and medication availability at our shop. We have Haldol, we have Versed, and we have Ativan at the ready. We also have droperidol and Zyprexa, and those have to be sent down from pharmacy. So always check with your pharmacist or with your administration to see what you're able to get readily, very quickly, and what is going to take some time to be sent down from the pharmacy. Now, when we talk about the best medications or combinations to give, a lot of considerations boil down to pharmacokinetics. What is the time to onset, and what is the duration of action? If you have someone who is violent with substance-induced psychosis, then we want something that's going to have a quick onset and somewhat longer duration of action, allowing the patient to metabolize the intoxicant safely. These numbers are based on somewhat subjective endpoints, so these times are going to be more of a range when they're used. But in general, and we're going to be focusing on the intramuscular route here, Haldol kicks in after around 15 minutes with a mean time to sedation of around 25 minutes and lasts for about 2 hours. Droperidol will be faster with onset at around 5 to 10 minutes, but lasting even longer from 10 to 4 hours, but it can last even up to 12 hours. For our benzos, Versed IM is around 15 minutes and with a duration of action between 20 minutes and 2 hours, and Ativan will be longer with an onset of 15 to 30 minutes for its onset and can last up to 3 hours. So these are the medications for which there's a level B recommendation, and we're adding on Versed here. Now let's move on to their second recommendation.
The committee's second recommendation was a level C recommendation suggesting considering ketamine to rapidly treat severe agitation when safety concerns for the patient, bystanders, or staff arise. Compared to antipsychotic or benzodiazepine-based regimens, ketamine has shown faster and more reliable management of agitation following a single dose, especially with intramuscular administration. However, despite these advantages, there remains increased discussion in the medical community regarding ketamine's safety profile for severe agitation. Ketamine does carry appreciable risks, including laryngospasm in 1 to 4% of patients, hypersalivation in up to 20% of patients, and a variable but notable risk of respiratory depression, ranging from less than 2% to more than 20% following intramuscular administration. There does exist a large variation in intubation rates. However, the authors attribute this to physician and departmental factors, such as unfamiliarity with ketamine use for sedation management. I do think that it's important, however, that we note that medical studies are constantly demonstrating ketamine's safety profile in procedural sedations. The committee therefore acknowledges that emergency physicians are well prepared to rapidly recognize and treat adverse reactions related to ketamine use. When utilized, they recommend close observation for potential respiratory and hemodynamic compromise, including continuous ECG, pulse oximetry, and continuous waveform capnography as soon as safely possible. I do want to note that there was no specific recommendation made for or against ketamine use in the out-of-hospital setting or in patients above the age of 65.
You mentioned the study out of Hennepin that presented very jarring numbers for the whole community. Ketamine is likely going to be the fastest way to control acute agitation via the IM route, with onset of action at around 5 minutes and lasting 5 to 30 minutes. So with the potential adverse effect profile and this damning data and other efficacious options, this has been reserved, in my opinion, for cases in which the patient's life is imminently at risk or staff is in danger of harm and there are no other options, or if you've already tried the other medications that we listed before and they're not working. If you're forced to reach for this medication, ensure that you have your airway equipment set up. Okay. Now, this point is likely not going to age well in podcast form because with time, we will hopefully get more, like you said, data on the appropriate role of ketamine in treating acute agitation. Now, switching gears, Jonathan, we can't finish the podcast without talking about QTC. So tell us how you process this consideration.
I think it's important to acknowledge that with these medications, specifically antipsychotics, QTC is always a consideration. However, it is worth noting that the data really demonstrates that these are safe medications. For patients who are receiving multiple dosing, we should be a little bit more mindful about their QTC. But for those who are coming from the emergency department and require rapid sedation, it is appropriate to give these medications prior to knowing what their QTC is.
Yes, and there's no ideal situation here. We have to acknowledge that we're going to be balancing risk with risk. All right, now we've covered the essentials for managing acute agitation. Jonathan, top us off with some final points.
Yeah. I'd like to round out this talk by discussing just a few situations that I believe require a little bit more nuance than some of the approaches we've discussed this far. First, for elderly patients and those with dementia or delirium, it is important to try to optimize the environment before using non-pharmacologic measures. I also try to avoid benzodiazepines in these patients due to risk of precipitating or worsening delirium. For patients who are able to take an oral medication, I might start with a low dose of oral Seroquel, such as 25 or 50 milligrams, or rapidly dissolving olanzapine. When IV or IM medications are necessary, I typically start with low-dose haloperidol. Remember in these patients to consider the effects of polypharmacy and try to review their medication list to avoid precipitating any side effects, such as an anticholinergic toxidrome. The one exception to this is Parkinson's patients. For these patients, we should avoid antipsychotics due to the risk of precipitating a Parkinsonian crisis. Another patient population that can be challenging to treat in these scenarios are pediatric patients or patients with autism spectrum disorder. For these patients, engage caregivers as much as possible who are likely familiar with previous episodes of agitation and may be able to provide information on what works best for the patient. I try to create a calming and low stimulation environment and provide distractions when feasible. Definitely try to involve child life services as soon as possible, as these folks are experts at de-escalation of these events. And lastly, I try to avoid aggressive maneuvers such as physical restraints and intramuscular medications as much as possible, unless absolutely necessary.
Perfect. Thanks, Jonathan. And thanks again for being back in the studio to talk about this essential, very complex, nuanced topic.
Always a pleasure to be here.